So I want to share a little bit about what we're doing today, just very quickly, and going through understanding self-injurious behaviors, or what you might see in this slide might be SIB, and also talking about a little bit about the assessment, treatment, and then getting a little bit into the shame. When I first started working in the field about 17 years ago, and then more recently, about 13 years ago, I was really, fascinated and very passionate about DBT work and CBT work and the profound impact it has had on our field and with our patients. But since then, as I've been doing this so long, I've been realizing that we're seeing, although we're seeing recovery and we're seeing cured, we're also seeing chronic. And something that I've really been working on with my therapists at my center is looking at trauma and really getting and building shame resiliency and getting to the core issues of what continues to perpetuate the eating disorder, the shame, as well as the self-injurious behaviors. So basically, a lot of this work that I've done today in these presentation can be applied across all ages. And so I just wanted to mention that. So I wanted to share just really quickly one of my favorite poets, or Shel Silverstein, and this is a poem called Help, and it's from the book called Falling Up. And see if it reminds you of something. I was reading this poem to my kids a couple years ago, and I thought about it after I read it. I'm like, this sounds very familiar. So let me read it to you. Again, called Help, and it says, I walked through the wildwood, and what did I see? But a unicorn with his horn stuck in a tree, crying, someone, please help me before it's too late. I hollered, I'll free you. He hollered back, wait. How much will it hurt? How long will it take? Are you sure that my horn will not scratch, bend, or break? How hard will you pull, and how much must I pay? Must you do it right now, or is Wednesday okay? Have you done this before? Do you have the right tools? Have you graduated from horn saving school? Will I owe you a favor, and what will it be? Do you promise you not damage the tree? Should I close my eyes? Should I sit down or stand? Do you have insurance? Have you washed your hands? And after you free me, tell me what then? Can you guarantee I won't get stuck again? Tell me when, tell me how, tell me why, tell me where. Well, I guess he's still sitting there. Does that not sound familiar? I was reading that to my patient. I said, oh my goodness, that's my patients. My daughter, who's like 7, is going, what, Mommy? What are you talking about? But it's so true. It's that state of ambivalence. Like, I really, really want to get better. I really want recovery, but I'm afraid. And the shame continues to perpetuate that. And that's what I see a lot with our patients with eating disorders or addictions. And I also wanted to read this really quick, because again, it speaks to that ambivalence of where they are, where they get stuck. And so please bear with me for 1 second. I feel caught in a trap between my mind and my body. I can't claim ownership to my body, and my mind is constantly betraying me. To heal, I must attend to my body. I don't feel my body deserves the attention. I don't want to feed it what it desires. I want it to starve, to go without. I want it to pay for the damage it has done to my mind, to starve until it has no choice but to disappear. It's like I want to live, but I want my body to die. I have become engaged in a battle. Whichever side wins, I fear I'll lose. How can I feel safe in knowing which voice to listen to? The one that says, yes, open your eyes, experience life as it is. Or the one that says, climb a little deeper inside yourself, for it is safer darkness. So I really feel like we're battling, like she said, this battle between the mind and the body, between, the fear and the shame and the eating disorder. And so that's what I talk about today is why, what's the purpose, what's the function of the self-injurious behaviors. And first, just to define and just to, quickly go through, self-injurious behaviors aren't suicide attempts. They don't have that intention. There's many functions to it, and I think it's really important to do the assessment of what the function of the SIB is, but just like the eating disorder, but there's so many different dimensions to it, not only physiologically, but emotionally as well. So in that respect, it's really a socially unacceptable behavior, but it is deliberate, it is intentional, and it is act on its own, our bodies. It can range from anywhere from cutting, biting their nails to the quick, scratching, pulling out their hair, although that could be an anxiety disorder as well, banging their head. I've seen people, scratching their wounds and then reopening scabs and all of that. So we see all the gamut. The most I see is a lot of cutting. And in our facility, if we try to keep them safe as best as they can, but oftentimes they'll just grab a rock outside and scrape on themselves, or their fingernails, or a paper clip. And so those are the things that concern me, because they'll go to any lengths to want to do what it takes to disengage or disconnect. So in terms of my one study that I think is really important, I thought that the findings of this, Dr. Peebles and Locke did a study out in Stanford when she was there, and they looked at over 1,400 charts, and what they found, looking at diagnosis, eating disorder, age, it was about 10 to 21 were reviewed in those respects, and 40%, almost 41%, reported self-injurious behaviors. These are eating disorder patients. And out of that, mostly were female. Binge eating was primary diagnosis or a history of, bulimia was the primary diagnosis or a history of binge eating disorder. They also included purging, and now it would be purging disorder, and then comorbidity with mood, substance abuse. So you kind of see a pattern, more on that impulse control spectrum, if you will. Although I do see more and more patients with anorexia who are also coming in with self-injurious behaviors. So more, though, in binging than restricting. And then what was profound that Dr. Peebles really pointed out was that providers often missed the self-injurious behaviors in the adolescents. And that's what we're seeing often too, and it's about 40%, and that you always have to ask, are you harming yourself in any way? Are you cutting on yourself? Being specific about what they come, because they will hide it. It is a disorder of shame, or it is a behavior of shame. So in looking just briefly out of this resource, Sanson and Livet, his resource says, their research says, that mostly about 25, if you will, on an outpatient basis in terms of prevalence. And if you look at inpatients with bulimia, it's about 25 as well. And outpatients with anorexia, it's about 16. But I have to say, and just in looking at our patients, I just did a pool of our 14 adolescents. On the way out the door, I just kind of did a real quick, analysis. Out of our 14, over 6 were self-harming or had a history of self-harm. So it is, almost, if you will, slightly, less than half. But it is interesting to see that it comes in waves, and I really see it a lot with substance abuse as well. So in looking at motives, let's see, where am I? It's hard to see where. Higher rate, okay, so just looking at again, the higher rates of trauma is prevalent, particularly in eating disorders who have this history of self-harm behavior. So individuals who self-harm, who have been sexually abused, are significantly more higher to report behaviors in eating disorders than those who have not been abused, if that makes sense. And then individuals who self-harm and have subject to sexual abuse have a higher rates of suicidal ideation as well. So again, there's a high correlation, and Van der Eyken's research corroborates that is with substance abuse, alcohol abuse, self-injurious behaviors in all types of eating disorders. So again, we start to see a pattern. And so what is this all about for them? Well, they do have this risk factors, the early abuse history, high levels of dissociative features, so we're seeing a little more psychopathology in these population, chaotic family environments. And somebody one time in a presentation said, well, don't we all our patients with eating disorders have chaotic family environments? Don't they all, have lack of sufficient parental support? No, they don't. So we get a lot of, families that, they come from good families, and, we know more. Like, Dr. Cohen said, we just don't blame the families anymore. We just don't blame the mothers. Thank goodness. Being a mother myself, that is refreshing. That I'm not. So there is this profile, though, the chaotic family environment. They have very little support in home. They're often bullied. And also one thing that we're seeing more and more and more, particularly at Rosewood, we see a lot of Medicaid or access patients, extensive psychosocial stressors, particularly related to poverty, so economic issues, and then the severe mood issues. So one of the things that I think is really important is not to assume what we think the self-interest behavior is about. Often I'll health therapists, well, it's a way of getting attention. Or it's a phase, or it's her way of emotionally regulating. And those could be true. Often so much it's not really about attention. It usually is a secrecy of the way they're trying to regulate. Every once in a while I'll get school reports and they'll say, oh, I think they're doing it for attention, and there may be an element to that, but usually it really is about having all these extensive emotions, and particularly as an adolescent, not having words to be able to organize it or understand it, and so it becomes and it reduces down to their bodies. It's a way of, showing on the outside what is happening on the inside. And so understanding the function is incredibly important, and we do a lot of that through behavior chain analysis and just the assessment process. We do a lot of that through pros and cons, which I'll mention that in a minute. But some of the identifications of functions could be it's a stimulating, escaping through dissociative experiences, numbing out. So it could be numbing out, but it could be grounding as well. So some of them are feeling like they're starting to kind of go into this darkness, and by cutting, it brings them back to reality in many sense. It gives them that stimulation. It's a way to release. They show anger on their bodies instead of anger towards somebody else, because maybe that's safer. It's relaxation, and we know physiologically it can be a pleasure response with the blood and the physical sensation, a reduction of tension through abreaction, and then it also can be a diversion. Like I said, I don't have to focus on my problems out here. I can just focus on this one thing that's right here. And it also is about getting into a trance, perhaps. There is a feeling of just numbness that, again, keeps them safe. And perhaps there are social motives. There is an attention aspect. Right now I'm in the throes of, I feel like we have a community that is really taking on the sick role, that their identity is about being sick. And so I wonder if a lot of their behaviors are the attention, even if it's negative, at least they're getting attention. So I'm trying to work with our community, like how do we get them out of this sick role? How do we get them to want to embrace recovery and motivate them? And then the other aspect is alteration, to make, their bodies seem unattractive. And we've seen this a lot with some binge eating adolescents as well. We see I've had patients with a lot of piercings or a lot of tattoos, and they will say, this is a form for them of, kind of destroying their body or showing on the outside what the pain is on the inside. Not all the time, so we don't assume. We always want to do the assessment. And that's also through the interventions that we bring forth. So some of the things that you can do, and I wanted to make sure to bring some tools to you today, is having them create a collage depicting the following. What do you think every child needs? And so this is kind of an art project that we bring out. And then bringing it back to what did you receive? And then what does your eating disorder help you meet in terms of your needs, or the self-injurious behaviors. So you can use either one for them. Write about how your eating disorder, your self-injury serves between a wedge between you and others. So is there something that it's keeping you distant from your friends because it's safer, or because you have extensive anxiety related to social aspects? Write out what you get out of your self-injurious behavior and why it works for you. Identify the unmet needs of what and why, and create urge cards addressing the function of the eating disorder. So we do a lot of cards. We try to laminate them, so we'll do 911 cards, skills that they could use, while they're at the table or after dinner, particularly at night. We find a lot of our adolescents are very vulnerable at night. They're homesick, and so bringing out these cards with whether they're drawings on them or songs. Sometimes I'll have the work that I do with the adolescents, I'll have them pick a theme song, and whether it's Stronger or, I don't know, one picked I'm so fancy, that song. And so they had that on their card. And so it's just something that they can, use to, escape a little bit and do something really fun and, again, feel safer at night. So having these cards are really important, but we have to know what the function of the self-injurious behavior is and then how to go in and be able to treat it based on, that lack or difficulty in the skill, if you will. Typically, I see it as a self-regulation, so any ways we can help regulate them. So in looking at dialectical behavior therapy, again, love dialectical behavior. I think it gives us a framework in helping us. It's as Linehan will say, hey, I just stole from everybody else and put it into a nice package, and that's what I love about this, because it's protocol-driven, but you can think out of the box, too. And so it's really balancing acceptance and change and helping the adolescent say, you know what, I accept you as you are, You know, I know why you do what you do, and I'm validating you. However, let's work toward other and more healthier coping skills so you can have a better quality of life. And it's really balancing. And the other aspect I like about DBT is it targets the behavior directly, so you can do specific protocol-driven treatment as it relates. And then you can help them understand, I know, as I talked about the help, the unicorn with his horn stuck in the tree, I know that you're ambivalent. I know that you want to change and you want help and you want to have a better life, but I also know the fear. And so again, accepting that is amazing. That's, you know, like Kim said this morning, sometimes they don't even hear that they can be recovered, that they, you know, that they are okay as who they are, because everybody's constantly saying, why are you doing that? Why do you do that to your body? And they get freaked out, particularly parents a lot of times. And it is a freak out thing. So motivation, that's the first things first, right? Doing a lot of the motivational interviewing. How do you get them from pre-contemplation to contemplation? And then understanding what do we target first? You know, life-threatening behavior. So that's the suicidal ideation, obviously, and the self-injurious behaviors, and obviously anything related to the eating disorder. If they're purging or if they're severely malnourished, we want to target those behaviors first before we get into any trauma work. First, it's obviously that we have to build skills at the same time, and so that's also, we need to put that in place before we get into the trauma work. And then therapy interference, obviously if they're distracting, oftentimes I do a whole workshop with my patients about how to stay sick in treatment, and a lot of time is complaining, distracting, avoiding, and wanting to change therapists, you know, all of that. So, and not doing a homework assignment. So those are the first things that we tackle, that you have to be present in treatment, you know, to be able to work on those deeper levels. And then oftentimes for therapists, I try to help distinguish between, am I in a crisis management situation with my patient, or am I in a therapeutic processing? I think that helps at least keep me sane. Like right now, I am managing symptoms. That is not my goal. My goal is to get into the therapeutic process and get to that deep, you know, work. But you have to kind of know what context that we're in, and that helps too with working with this population. So here's some cool a toolkit that I like to do, just briefly, so you have some things some ideas. We do a art therapy assignment with all our patients that come in. You know, tell me about your eating disorder. Draw me a picture of Ed and me. Or draw me a picture of your self-injurious behavior in you and what that looks like. Fascinating. That is your assessment of looking at what role does it play in their life, what does it give them. We also do body as a house, because I want to know, you know, on the outside they may be presenting one way, so their house might be very beautiful and painted very nicely, and flowers are in the front, and there's a nice rocking chair on the patio. But inside, it might be falling apart. And so what do their walls look like? How is it sectioned off? So then we just say, very little instruction, just if your body were a house, what would it look like? And it gives them, again, insight into what's going on. We do, again, I'll go through pros and cons. It's just a vertical and horizontal line. What are the pros of your eating disorder? Or sometimes I use cost and benefit. Cost of your eating disorder, what are the benefits? What are the costs of not having your eating disorder? What are the benefits of not having your eating disorder? And they're very different questions, and sometimes they'll relate and overlap, and sometimes they'll be very different. Also, I'll go through a behavior chain really quickly, and of course we do diary cards or 911 cards or coping cards, whatever you want to call them. And then, as I mentioned, always having a theme song. I love the phones nowadays. I think that I love the YouTube that you can just pull up any song and get right there with an adolescent and connect with them. And I had a boy adolescent that, let me tell you, I learned everything there was about Slash and Guns N' Roses, and we just had the best connection. So every time we started our session, I'd get on YouTube and we'd pull up a song and listen to that song, and it just set the tone, and it was our connection, and it was just a great way to be able to think that I get him. You know, so yes, I did read the autobiography on Slash. Okay, so just so you know. But that's what we do, right? And I know who Slipknot is now. So anyway. Very fun. I love the kids. So BCA, behavior chain analysis, it's Linehan's work. It's nothing I made up. I wish I did. I wish I would have written all the 30 books that are already out on eating disorders and DBT, because it's good stuff. But the thing about this is, again, we're not assuming, we're trying to get them to go through this process, and it may be laborious, but to understand why they do what they do. And sometimes I'll often ask them, are you curious about what this behavior is about for you? Because again, they're so cut off, they're alexithymic, they're numb. And I'll question, I'm wondering, are you curious why I'm more curious about your behavior than you are? Because I really want you to question, what is this about? So that we can figure out other ways to get your needs met. And so quickly, it's identified problem. What made you vulnerable? So what triggered? The boyfriend broke up with me. What made me vulnerable? So this is HALT. Physiologically vulnerable. Were you too hungry? Were you angry? Were you lonely? Were you tired? So what made you physically vulnerable? Well, I was tired, my boyfriend broke up with me. And then what are thoughts, feelings, and behaviors that led to self-injury? Because it didn't just happen. You just didn't start cutting on yourself. Well, let's see here. I felt shame. Well, I felt upset. No one loved me. That's a thought. And then da-da-da-da, I go to the bathroom. I grab a razor and I cut. So helping them back up and go through that process, then you go in and say, okay, well, what happened? Well, I felt relief. Then what happened? My mom came to my rescue. We went shopping. And then what happened in the long term? What was the long-term result? Well, I felt shame and guilt. And then there goes the perpetuation of the behavior again. So we have to begin, okay, well, what can we do? Well, we have to break the chain. So what skills, what could you have done different between grabbing the razor blade or between whatever? I could have made going to the bathroom. Well, I could have made a grateful list. I could have called a friend. I could have done this skill or I could have done that skill. So that's the idea, is helping them understand that you have choices in this. You feeling these deep emotions, you want to numb out, but the key is to do the skill before they get to past the point of no return, because we know once they pass that threshold, it's really hard to get them back. Okay, mindfulness 4 modules. DBT, 4 modules of skills: mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. Goes along great, as we all know, with the difficulties that the eating disorder, the self-injurious behaviors bring about. They have difficulties with being in the moment. They have difficulties with tolerating distress, and so on. And so these skills are wonderful in that aspect. So after years, as I mentioned before, I realized, are we really helping our adolescents today build resiliency? I know that we're focusing on bullying and shutting down bullying in the school, and we're very aware, but are we building resiliency in children to withstand some criticism, to withstand constructive criticism sometime, or feedback from others, or gossiping? Because we can't shut and control everything. But are we building within character within our adolescents to do this? And this is the same with shame. Are we building shame resiliency in our children? And so that's something that we've been focusing a lot. Again, we're looking at understanding the function and processing the trauma and getting to the core. So here's some just what I understand about shame. It's, defining it is that feeling at the pit of your being that you are not worthy. There's a lot of self-loathing. There's feelings of rejection and outsider. It's demoralizing. It's intense, painful experience that really lead to feeling unworthy and unacceptable. And so being able to start to build protection against that. We know that shame functions as a way to protect them. So does the eating disorder. So does the self-injury. It protects them from feeling those events. And it also blocks the core work. And it also, if it goes unresolved, I really feel that, it's really hard to get out of the eating disorder. We can learn skills all day, but until we get to that core trauma, we will really be remiss in really dealing with what's going on in terms of the shame. What can I say? So recovery doesn't equal to toxic shame. It works most effective when we begin with the shame resiliency. We have to address this before we get to the attachment and the traumatic events. And then we also have to understand that it's like I like this line, is attempting to consume the flesh of the apple first without consuming the pill. So again, first things first, beginning with those skills, looking at what, building the shame resiliency, and then getting to the core. Eventually, though, we have to get to the core. The problem is, particularly those with eating disorders who have a long duration. I have a 17-year-old who's already been in 4 treatment centers already. And so her shame is so embedded, but there's so much medical and nutritional issues that we're having to deal with because of the complications that it's hard to get there in our level, let me say it, in our system, our health system, because they need long-term care, and we all know what it is. And once she reaches a weight, we all know she's probably going to be discharged because insurance is going to say that she's recovered. I love that. Let's not talk about that right now. So building shame, it's really asking for what you need. Really, it just sounds so easy. Just ask for what you need, you know. Speaking your truth, owning your story, setting boundaries, and what does that say at the bottom? Reaching for support, of course. And I just love, I'm not going to go through this. Again, it's all, there's actually 7 more slides in your little thing. But one thing I love, I mean, she just sums it up, Maya Angelou says, you will face defeats in your life, many defeats in your life, but never let yourself, what does that say? Free to feel defeat. Thank you. I can't read. But I love her work, and I think it just captures, you know, again, what are we working towards? So I love this. Here's how we start it. 4 crucial questions. Who do you become when you are backed into the shame corner? Who do you become? What happens to you? So these are the questions for our patients. How do you protect yourself? What do you do? How do you call to work through the mean nasties or the crying highs or the people pleasing? How do you work through that? And what's the most courageous thing you can do for yourself when you feel so small? What can you do? So give me an example the other night. I was stressed. I was tense. My 10-year-old was driving me crazy. You know, wouldn't stop talking. He wants an iPhone. That's his newest thing. I want an iPhone. I want an iPhone. No, you're not going to have an iPhone. No, stop asking me about it. Stop asking me about the iPhone. No Apple products in the house right now. I was like, this guy lost it, okay? So immediately that night I was laying in bed, I'm like, oh, such a bad mother. I shouldn't have yelled. And so sitting in that shame, if I would have stayed with that, I'm a bad mother, I'm a horrible person, this is terrible, that's sitting in the shame. Getting out of it, reaching out, and working through it is getting up, going to my son and say, Mommy's really tired. I'm sorry, I didn't mean to yell. That's working through the shame. That's helping our patients deal with what's happening, because we're all going to feel it, we're all going to lose it, but the difference is what are you going to do about it? And so that's what we're trying to teach our patients, working through it and not sitting in it. And no, you still can't have an iPhone. Family, I'd be remiss if I have a whole talk just on working with families, so please, the 3 R's. I have 1 minute. Recognizing behaviors that are part of the illness, so recognizing that this is part of their illness. You know, this is not something that they're doing on purpose or because it's, to get your attention. It really is part of their illness, and understanding, and sometimes even labeling it that. That's their eating disorder. Not to be helping them not to be judgmental, helping them to validate their child and understand that whole process of validation and change. Also resisting being caught into the vortex of the dysregulation and the self-interest, not to be overreactive when they see it, and then accommodate the behavior is really important. And then reconstructing, what does this relationship look like now? I often say an eating disorder will change your life. You have to reevaluate, redefine the relationship. We all have these visions of what this child's going to be like when they're born, and we have dreams about our relationship with our children. And sometimes that has to be renegotiated or rethought out or reevaluated. And we have to look at it for what it is, because this eating disorder, the self-injurious behaviors, the addiction is going to change them and your lives, but it doesn't have to be negative. It can go in a different way. And so helping families understand that is really important, that they can grow and learn from this and become closer. And that's it.